Yeah, good morning, and thank you for having me. I'm a neuroradiologist, I'm not here actually to give a didactic lecture on fMRI or clinical fMRI service. However, you can say I just want to share an experience, okay? Tell a story, maybe. I'm bad at telling stories, but yeah. So, so we had a challenge. I joined this place, Ibn Sina Hospital in Kuwait, in 2018, actually I started my career in Egypt, in Africa. I have my radiology residence training and my medical degree, and then I moved to the U.S. for fellowship training and other, fMRI dedicated training, and then I moved to Europe for having more degrees, and then finally I landed in the fourth continent, which is in Asia, in Kuwait. And these transitions probably they represented a challenge in my life, and I brought this challenge with me when I went to Kuwait to establish fMRI almost from scratch. So I joined this place 7 years ago, and Ibn Sina Hospital is the national hospital for neurology and neurosurgery in the country. It's affiliated to the government, operated by the government, and it's the main hub for referring brain tumor cases, especially complex cases. And when I joined the place, I just figured out that it was very well equipped. They have state-of-the-art scanners and hardware and software, even for fMRI, but they have never done fMRI cases before. So I thought my job was very easy. I was challenged again, and I was very encouraged to prove myself. So I collected some data about craniotomies, about the types of brain tumors, and age distribution, and I thought I can call all these departments, and I scheduled a meeting, and I was very enthusiastic. I brought my head of department with me, radiology department, the director of the hospital as well, who was a neurosurgeon at this time. And I went with a very clear message that, guys, we want to start this project, okay? So, because fMRI will help you identify eloquent areas non-invasively, which will reduce surgical risk, and it will enable you to do the mapping when other methods, fail, which will eventually support safe resections. But guess what? I was wrong. I was totally wrong. They didn't accept what I said, especially neurosurgeons. They were very, very resistant, and I can remember two faces. They kept looking at me all the meeting, and they were about to kick me out of the room. They said we're happy with what we're doing. We don't want to replace it. So I was disappointed. I went back home for 2-3 weeks with mixtures of feelings, mostly negative feelings, and then I tried again. But this time I was able to figure out that there should be a smart way to introduce change to people, because basically most people resist being changed. And these resistant factors in the case of fMRI could be unfamiliarity with fMRI itself. Although most of the neurosurgeons I'm talking about had their training in the West, and they are familiar with fMRI, but they're just happy with what they're doing, that's it. So they prefer to do intraoperative mapping instead, and some of them may be skeptical about the clinical utility of fMRI. So how to overcome these barriers, especially for those who are going to start a new service. So you should prepare your evidence from the literature and should share it with them. But more importantly, you want to show cases as well. Because when you see your case, one of your own cases, this is much better in terms of convincing surgeons and convincing people to change their practice. I know this is not very scientific. The level of evidence in the literature should be stronger. But seeing a case, a real life, people love to see a real life experience. But again, the challenge is still there. We need to engage at least one neurosurgeon to send at least one case to start this puzzle, to solve this puzzle. So I prepared the evidence, and I really like these 5 papers from the literature. I usually start with them when I talk about the utility of fMRI. So because fMRI would help change this treatment strategy, maybe modify the surgical entry point or the extent of resection, might change the treatment planning, and will reduce surgical time up to 60 minutes. It can also help those people with intraoperative mapping to change their, to have a roadmap or to change the way they plan for intraoperative mapping. It's concordant with WADA and so on. And one of the very, very classic papers that I'd like to share with you, this meta-analysis is a strong one on 68 studies, and it tells you that the adverse event rates for those people who do preoperative fMRI is almost half, is almost 50% less than these adverse rates for those people, for those patients who do not perform preoperative fMRI. And one of the papers that I really like to share with you, this one published in University of California, San Francisco group, and you can see here these patients who had presumed eloquency on MRI, on anatomical MRI. But when they did fMRI, the blue group here, they did fMRI and the lesion was found to be in a non-eloquent area. So look at the extent of resection. So how it's the widest resection for this group who were presumed to have eloquency on anatomical MRI, but with fMRI, it turns out to be not eloquent, compared to the purple group in patients who had presumed lesion to be eloquent on MRI, but when they did fMRI, they didn't do fMRI at all. So and this actually in turns eventually affects the survival matrix as well. And you can see here patients who have lesions in the non-eloquent areas, they live longer than those have lesions in eloquent areas, just because of the extent of resection. Well, so at least I was able to convince one of them, okay? And I received my first patient. So we have our first patient for fMRI. And as you can see here, this 18-year-old girl, and she has an ugly-looking lesion with necrotic core and irregular enhancing rim all around and edema and so on. And I usually start with this axial scan for, when I speak to a neurosurgeon, and I ask them, there were many of them in the room, and I asked them, where is the motor area? So the most basic question. And when you look at the right side here, you see the superior frontal sulcus intersecting the precentral sulcus. So the sulcus behind it is the central sulcus, with the precentral gyrus, the thick one, anterior, and the postcentral gyrus, the thin one, posterior. So the hand knob area on the normal side is here. But what about the left side? What about the side with the pathology? So I received different answers. Some of them said it might be anterior, here it might be within the lesion. I received also a third answer that might be displaced. And then we did the fMRI, and then it turns out to be anteriorly displayed just along the anterior rim of the lesion. You can see here in the coronal planes as well, it is in a different plane because it's displaced compared to the normal side. And we did also DTI, the coracospinal tract, supported this finding with the coracospinal tract traversing the most anterior part of the abnormal flare signal. Lesion was resected without deficit, and everyone was happy. And then I received my second patient, just on the next day, I received my second patient, but this time was quite, different because the same neurosurgeon. Oh, you know what? This is one of the two guys who wanted to kick me out of the room. Okay, so he sent this patient and he said okay, so what about we want to see the hand motor area? I said, so what about the face motor area? Because this one is quite lateral and more inferior. So let's look at the face. Oh, can you look at the face? Yes, we can do. And then we did face motor activation task. But I asked him first, where do you suspect the face motor area to be present? And I received, again, different answers. And when you did fMRI, we didn't find it at this plane because it was actually displaced more inferiorly and more anteriorly by the lesion. But this patient, there was a frozen section biopsy for this patient because it was a lymphoma. It turns out to be and lymphoma, they don't treat lymphoma with total resections. They just take a biopsy because most patients with lymphoma respond to chemotherapy. So imagine what's the tragedy that would happen if if the whole area was resected while the face motor area is here, because they typically resect the enhancing and the non-enhancing component of the tumor in the case of primary brain tumors. Well, so in those two cases, I didn't give appointments to the patient. I tried to squeeze the patient in my schedule because we wanted to to start our service or to have these pilot cases. So we did very well. We received a very nice feedback, and then we received the third call for the third patient. But this time I said, okay guys, we're busy, so we need to take an appointment instead. And they took an appointment for the third patient, but this time it was a language case. And the lesion looks very benign, as you can see here, and it has an enhancing nodule that I'm not showing here. It has this huge cystic part, and it was involving somehow the superior temporal lobe as well. And the question where's the language? And you can see here with the sentence completion task, the Broca's area is here on the left side, and you see also some sort of middle frontal gyrus exoner area, and which tells you a lot about lateralization as well. But where is the Wernicke's area? So, and as you can see here, it has crossed from this left hemisphere to the other right side in a pattern that is known as reorganization of language or reorganization of Wernicke's area. And this was extremely helpful to the neurosurgeon because they canceled the awake craniotomy in this patient because it would give nothing, searching for like endless searching for something, and they were able to remove the whole lesion without any deficit in this patient who works as an English translator. And the patient is right-handed, by the way. So speaking of handedness and language lateralization, it's not always simple. And I'm just sharing you my experience in Kuwait, because relying on handedness, that most patients who are right-handed, like 96 or 98% of patients who are purely right-handed will have left dominance for speech. However, we use this form for handedness. We don't just ask right-hand versus left-handed. We do some sort of scoring system. There are longer forms, but this one is a summarized one, and we use it to give a score and to know exactly how what's the percentage of handedness in these patients. But you know what? Sometimes we get weird results like this one. This patient was seen very recently. The patient is using left hand for most of the tasks. But with eating, she uses the right hand. Does anyone know how to explain that? Especially if I tell you that this patient is a Kuwaiti local patient. So this is purely for religious reasons. Okay. So what I'd like to say is that there's a difference in culture. Some people may want to use the right hand for their culture, for their religious beliefs. And even with writing, it happened that in some schools, especially in the past, teachers used to force kids to use the right hand for writing, although they're so relying on just handedness, is not always true. And if you look at this funny curve about the history of left-handedness from the U.S., it can tell you that that in the past many people were not left-handed simply because of the stigma that was in the society. I know that most left-handed people are smarter and are even genius, So, but this was true. So, so we started to have a vision at that time. We started to have a vision and to have a program that we can establish together with, the aim of building a sustainable, what we call sustainable fMRI program, with the goal of guiding safe resection. But of course, we need to support training and education as well. And whenever you start any program, this is something that I'd like to share. I know everybody knows that, but I'd like to share with you what we really did in Kuwait. Whenever you start a program, you need to define first who are the stakeholders. And if you think of like neurosurgeons, neurologists, psychologists, maybe MR physicists, but actually the list is much longer than this. So the list turns out to be, so there are many stakeholders, and if you are lucky enough to have a neuroscientist, to have a knowledgeable MR physicist with you, or to have a psychologist, this will be a big plus to your program instead of just working from the clinical mindset. Even anesthesiologists should be engaged also because everything is under the umbrella, the care of anesthesiology in the OR. So what about patients? Patients are, stakeholders in any clinical service. But in the case of fMRI, we found that patients are very critically important. Because you know what? We had many stories with patients who went back to the neurosurgeon after the scan, and he said, no, we don't want to do the surgery because they started to learn about, okay, are you testing my language? Because the lesion is very close to the language area, so they changed their mind. And we have also other, the opposite exactly, where patients go to the neurosurgeon and ask them, we heard about functional MRI. Why didn't you ask for pre-op functional MRI for me? I heard that my relative had a meningioma resection and they asked for fMRI, for example. So patients can lead, the story. Well, so at that point, you want to have an action plan. And this is our fMRI and action plan. I'm not going to go through all these details, but I want to, highlight or come across some of these steps. These are not steps, by the way. These can go, simultaneously together at the same time. But let me just, make some highlights here. So first of all, you need to study your resources, your hardware, very well, very carefully. Okay. Of course, it's preferred to have a 3 Tesla scanner. This is ideal, and you look at the numbers of channels in the coils. Also get some information about the gradient amplitude and the slew rate, because these might define the spatial resolution and the temporal resolution as well. So these are important, parameters. Of course, understand what can happen. What's the expense in changing the TR? And how can you go, when you change the TR, you're going to change the temporal resolution as well. But what's the price? And a thicker slice would give you higher SNR. However, a thinner slice would lose some sort of the SNR, but it will give you more spatial localization, and so on. Do you have multi-band acquisition or not? Do you have simultaneous multi-slice acquisition or not? Understand about the artifacts, especially metals and the blood and hemorrhage tumors. Many tumors are hemorrhagic. I'm talking about pre-op, not even post-op as well. And then the tools that you have for scanning. We have a stimulus delivery system from Nordic, and then you do the post-processing. But you can also do paradigms, design, home-based, home-designed ones, which is paradigms, design is not a black box. There's the potential room for improvement and for adding your inputs as well. And then for your results, discuss this with the neurosurgeon. So what kind of overlay they like. We used to overlay our results on 3D T1. Now we changed this to FLAIR 3D because most of them want to understand how far is the lesion from the edema around it, what kind of color coding maps they prefer or they understand, and then the neuronavigation, what do you have at your hospital, because there should be compatibility and there should be some work between the different vendors to make sure that you have the most accurate neuro navigation linking to fMRI. Then you have a pipeline, you have a workflow, and this must be very accurately defined, like when are you going to start who will receive the request? Is it just a written request? Will there any verbal communication? These things are very, very important when you plan for an fMRI service. And then do the patient training, ask the patient to come or go to the patient, assess ability of the patient, cognitive ability or motor ability or whatever. Especially in brain tumor cases, you might expect these things. You don't want to get bad surprises, just in the last minute. And then who will do the analysis, who will do the interpretation, and then we plan for an MDT just before going to surgery, and then we receive a post-op feedback. So this is a list of the paradigms we're currently using in Ibn Sina. I'm just showing this because I want again to say that paradigm selection is not a black box. So there should be a room for improvement. So for example, we noticed that when we give it more challenge in patients with face recognition paradigms to activate the fusiform gyrus, when we add these dots to the pictures, this might result in more robust activation in the fusiform gyrus in this patient with left-sided inferior temporal lobe tumor. And we always test and validate paradigms before we use them on volunteers. And if we don't find volunteers, we test them on ourselves. Yeah. Then this is the approach or the strategy. I call it a strategy or approach that we use for paradigm selection. Paradigm selection is a critical core component of your fMRI pipeline. And then, so we do this with deficit intervention. So identifying the location is crucial, of course. So you need to review the images right before, with enough time before planning the study, and then understanding the deficit, because sometimes the location might not give you all the information, but maybe the patient has some sort of deficit that is not explained by the location, but you need to add this paradigm to investigate or to know to explain that. And of course, it will tell you again some information about the ability of the patient. What about intervention? Intervention is important. So this is why I discussed the case with the neurosurgeon before making the study. I don't rely on the request. So I asked the neurosurgeon, what are you planning to do? Are you planning to do total resection? Are you aiming at subtotal resection? Are you just satisfied with a small biopsy? Because all these things might, change the way you examine your patient, scan your patient. And we have this list. We call this like the job sheet, where we actually mark all the paradigms and we want to do, and the 3D reconstructions in the case of DTI. So, for example, another case I know people, especially in hospital-related. With hospital-related practice, they want to see cases. So this case is a 35-year-old man who's right-handed, and he presented with this lesion, and you can see in the bilateral hand motor area, hand motor task, the motor area is just displaced by the lesion, and the sensory area just behind it. And the question here was like where to approach the lesion. So the neurosurgeon understand that there is a small, very thin, sulcus effaced in between the lesion and the hand motor area, especially deeply. But how can I approach this lesion? Because the original plan was to come from here, and then they changed it because the face motor area might be here. So they changed the plan to be just posterior and come from above again. But when we did this patient, we noticed something that nobody told us about this. We noticed that the lesion, although the lesion is on the lesion here is on the right side, we noticed something, that the lesion is very close to the Hatchell gyrus. Can you see the Hatchell gyrus? This is the primary auditory gyrus. And it looks like duplicated. It has like double shape in this, So we just, especially in the FLAIR plan, when you see the functional MRI, we did auditory task, and we received duplicated activation in the auditory gyrus, and the posterior limb of it is just abutting the lesion. And although the lesion was a low-grade astrocytoma, but the neurosurgeon just decided to preserve this part. And the old school of neurosurgery, they didn't care that much about auditory gyral resection because of the bilateral representation. So, but in modern neurosurgery, they care about it because this carry very important information in terms of higher processing of hearing, and I think we will have a talk about that. So the tumor was resected without any deficit. I have this. So in Ibn Sina, we do fMRI frequently in extraaxial tumors. And the reason is simply because they just want to know the entry point, and to plan the trajectory that they're going to use to be as safe as possible. And in this example, although it came back as a solitary fibrous tumor, which is quite more invasive than just a meningioma, you can see here how the motor area is just displaced posteriorly and pushed by this extraaxial large tumor. But why does the patient have speech impairment? So I remember this patient. I spoke to him. He has some sort of slowness in fluency. So he has impairment of his fluency of speech. He thinks a lot before he plans to speech. Some kind of aphasia. It's not aphasia, but it's not. It's kind of slowing of the fluency of language. And we couldn't explain it based on. So we did a language fMRI for this patient. And it turns out that everything is in place far away from the lesion. However, we thought that so this is the Broca's area and Wernicke's area is here, and we thought, what is this? Like this is very close to the singular gyrus, but it might also be the pre-SMA for language, but it's pushed by the lesion, and this might explain the lesions, the symptoms given by the patient. We were not sure, to be honest, but we told the neurosurgeon, and we did DTI, and this was actually more useful to see the frontal ascending tract, which connects the pre-SMA for language to the inferior frontal gyrus, that is actually pushed by the extraaxial tumor in this location. So you know what? Day one post-surgical, patient was relieved, completely recovered. So speech, and he came to my office. He was fluent in speaking. Well, so these are the happy cases. Of course, there are bad cases, okay? But I'm showing you some happy cases, and the other thing is how to communicate findings. So moving to this part, which is again a core component of any successful fMRI service. So you need to have surgeons and other stakeholders, talking together, pre-operatively and post-operatively. And what we do, we don't just rely on the templates of reports that, as the one you see here. We give them all this information, but we plan for interactive sessions. So with every single case, they come, we sit together, and we do the post-processing, or at least parts of the post-processing. I know this is time-consuming, but we do that. So we show them exactly how we control, for example, the alignment, the motion correction, and how we do, when you see an area of activation that is suspicious, we follow the time course of the hemodynamic response and to convince them. So everyone gets an idea about, have insights about the validity of the results. And this is very important, but you need to control the time, of course, because this might take, consume the time. And even the thresholding of the activation, how can you get false negative, false positive versus the true activation? And again, I think this is one of the key factors behind any kind of success we've accomplished. So I'm not gonna spend much time in the quality assurance framework because I know we have the second lecture. We have a lecture today about this topic, which I personally would love to hear. But what I'd like to highlight here is that again, the task compliance is very important. I know this issue was also addressed by Dr. Voets. The task compliance by the patient. Someone needs to be inside the scanning room to look at the patient and to see what's happening. Okay, and also assessment of the ability of the patient before that. We've been working on NVU, the neurovascular uncoupling, when you get false negative activation. So there's no activation just because of the neurovascular uncoupling effect, and there should be other methods to control that. Well, so. Going back to the fMRI in action plan, and this time I want to show you one thing that we, from day one, we started to work on operational policy. And this is something that is very helpful because when you write down something, it would help you, tackle all the weaknesses or the negative things that you have. So you did a policy, we documented all the steps, like for the generations who will come after us, like when you receive a patient, what are you supposed to do? Who will, give the decision? Who will do 1, 2, 3, 4, and so on. So this operation, and we keep updating the policy. And this was also, again, one of the ideas that I'd like to share with you just for, it was, our experience with it was very, very helpful. And then we created some opportunities for national, regional, international collaboration as well. So we started to recruit patients from other hospitals and to speak to doctors from other hospitals as well, to receive them for imaging and to do some workshops together at the regional level and also at the international level. So we were lucky enough to be invited by the ASNR in 2022 to present our experience in a very nice session, international session. They called it International Neuroradiology. So they invited a speaker from every continent across the globe. And we were there sharing our experience. I'd like to show you some of the beautiful pictures of our workshops and when we invited guest speakers. This is Harris Sayre from Hopkins, American Society of Functional Neuroradiology, collaborated with us at some point for a hands-on training workshop that it extended over 2 days. And these are our techs and our group presenting topics and having training and receiving certificates from the head of the department. What I'd like to say here is that training is a core component, which is consistent training, because in fMRI, the case of fMRI is quite different than other areas in neuroimaging. There is significant shortage of expertise, worldwide. So that people who can do independently fMRI are not so many. So I'm sure this group actually does not represent the whole neuroimaging community. Well, I'll see that these are my future directions because we still have some weaknesses. And it's, again, I think you agree with me that it's important to address your weaknesses, every day. So you know that you need, for example, resting state fMRI for those patients who are incooperative or sedated, kids for pediatric protocols. We're not good at that. Everyone is talking about AI enhancers and AI enhancement, protocols for imaging. And we are looking to do some sort of accreditation to our site. And I'd like to discuss this with you maybe after the meeting if anybody has, ideas about that. Well, so my takeaways, to recap. So for any project, such as a clinical fMRI service or anything else, like, you need to set your goals, of course, and you need to monitor your quality. But more importantly, in the case of fMRI, you need to build this trust. So whenever you have, the feedback we receive now from neurosurgeon, I didn't tell you that they keep posting on social media, successful cases and all these things, and we have a waiting list, and we are purchasing a new 3T scanner. So this is the case what we're having now in our hospital. We have 5 scanners, but we used to have to use one of them for fMRI. Now we are purchasing a new one just because of the queue of cases that we have. This is our group. I acknowledge every one of them for the limitless support that they do. And this is that brings us to my final slide. And I just noticed, I told in the beginning that I work in Ibn Sina Hospital, but I'm not sure that every one of you knows who is Ibn Sina. So Ibn Sina is Avicenna, the same name, but this is the Arabic name. And Avicenna was actually a historical figure in the history of medicine and medical educationalist and a genius physician at his time. And he published this book, which is called The Canon of Medicine. It's a 5-volume huge encyclopedia that was translated in numerous languages and served as the standard medical curriculum for 600 years in Europe. And this is one of the copies that is kept in the Library of Congress. And you can see here the picture of Ibn Sina performing a craniotomy to one of the patients, with those people are trying to stabilize him. This is very scary. But again, at that time, unfortunately, there was no functional MRI. Okay, there's no function. Yeah. Thank you very much for your attention. Thank you.
Thank you. Wow.